Welcome all of you. Welcome to our pharmacology session where we are going to discuss some of the most important MCQs for the upcoming NEET examination. I am your pharmacology educator, Dr. Arpit Agarwal, and the session is brought to you by Unacademy, the best online learning platform. So let's begin. Brief introduction about myself. I am your pharmacology educator on Unacademy, Dr. Arpit Agarwal. Avinash has joined us. Avinash says, good evening, Avinash. And today we are going to discuss some of the most important topics in latest pattern MCQs. So I've been teaching for over 10 years now, and overall this 10 years I have tutored more than 50,000 students preparing for both the AIMS NEET PG or the PGI or the FMG screening examination. So as I said in the beginning, Unacademy is the best online learning platform, brings you the Plus subscription, the signature subscription. The Plus subscription gives you daily live classes with the top educators. In very structured manner, we have batch courses for the Plus subscriber. These batch courses cater to the needs of FMG students, INI, CT students, NEET students. You also get access to live tests and quizzes. Obviously everything is unlimited. So Plus subscription gives you the access to live classes from the top educators sitting in the comfort of your homes and in a very safe environment given these times of COVID. You can also go for the other subscription, that is the Iconic subscription. Iconic brings you best of two platforms, that is the Unacademy with its live classes as well as the Prep Ladder. So if you subscribe for the Iconic subscription, you will get the live classes access, plus you will also get the video recorded apps of the Prep Ladder. So it brings you best of both the platforms, Unacademy as well as Prep Ladder. As I said, we have several new batches every week. Just to mention, if you subscribe for Plus or the Iconic, you will get access to this INI CT 24-day MCQ marathon batch. Also, you'll get access to FMG test and analysis. So whatever suits your requirement, you'll get access. Plus, these are just to name a few. These are just a few courses that we have. We have host of other batch courses for Plus subscriber to which you will get access. And the best thing is you can subscribe to as many batches as you want. Needless to say that there are best educators from the country on single platform. You get PDFs, you get live interaction, you get revision of the important topics. So we have the complete batch courses where everything is discussed in detail. We have the rapid revision courses, we have the MCQ courses. Every type of courses are available for the Plus subscribers. So now, please remember the code Dr. Arpit Agarwal. Now, how does it work? If you are the first time downloader of the Unacademy app, use this code and you will be able to unlock the free classes. So there are several free classes that you can unlock, and then you can watch those free classes and then make up your mind whether you go for Plus or the Iconic subscription. Both the subscriptions, as you can see, are available in a varying duration of time, so you can choose according to your convenience which one do you want. And accordingly, using this particular code, Dr. Arpit Agarwal will also give you a 10% discount. Now, coming to our topics for today and tomorrow. So, we are going to discuss the most important MCQs in part 1 and part 2, that is today and tomorrow. We will be discussing these particular topics. 9 p.m. is the time, 9 to 10 p.m. we will discuss. Let's start with the most important MCQ, part 1. Tomorrow we'll have part 2. So first statement, and now please, before we start, let me clarify one thing. These are the most important topics. Today we'll take up CNS, hemat, endocrine, and I have made them in a latest pattern covering all the important points from that particular topic. So first important topic in pre-PG from CNS is absence seizure. We frequently find a question on absence seizure. So it's a very important topic, and everybody preparing for pre-PG should be aware about this particular important topic, absence seizure. So what all are true about absence seizure? So let me know. Let's see. First question, true about absence seizure are. So select which all statements are true. So as I said, all important statements about that topic are presented to you. So that is what you need to remember in that particular topic. First statement, typical presentation is a child with sudden lapse of consciousness, or what we call as staring episodes. So is that the typical presentation? Answer, this is a true statement. This is a true statement. In absence, there is no convulsion that we see. All we have is patient is usually a child and he stares into absence. He is just staring. These episodes will be sudden and brief. They can last for a few seconds. So staring episodes in a child, that is typical of absence seizure. And during this, the child is not conscious. He cannot remember after this episode what happened. EEG shows a 3 Hz spike and slow wave. This is a typical presentation of the absence seizure. 3 Hz, 3 per second spike and wave pattern. That is the typical presentation of the EEG in absence. So that is true. Valproate and ethosuximide are first line option. Absolutely correct statement. So if there is simple absence, we give ethosuximide. If there is absence mixed with any other seizure type, we give valproate. So both are first line options. Carbamazepine, phenytoin should be avoided. That is also true. Along with carbamazepine, phenytoin, some other drugs like vigabatrin, drugs like gabapentin, drugs like tiagabin. These all drugs along with carbamazepine and phenytoin, they should be avoided because they all worsen absence seizure. All of them worsen absence seizure. So in my opinion, 1, 2, 3, 4 all are true, and that is why Avinash and Manas, the correct answer is D. All are true. All are true about absence seizure. All are true about absence seizure. These are the only 4 lines you need to remember in absence seizure. You can check any question of absence seizure. Answer is written in front of you in form of these 4 lines. So agreed? Manas, Avinash, Kaushik, everyone? Answer is option number D. All are true. Valproate, ethosuximide are first line option, and you will avoid carbamazepine and phenytoin along with vigabatrin, gabapentin, tiagabin. They all will worsen absence seizure. So you have to avoid them. So that is the first question. Absence seizure is an important topic we have covered. Keep marking the topic. Absence seizure is topic number 1. Second, another very frequently asked question, antidepressants with minimal sexual dysfunction. So we all know SSRI. SSRI are very notorious for causing sexual dysfunction, which include decreased libido. Decreased in libido, they include delayed orgasm. It also includes anorgasm, no orgasm, anorgasmia. So SSRIs particularly cause these sexual side effects. Now the question is, which antidepressants have minimal sexual dysfunction? So select all of them. Select all of them. Okay, it's a very important topic. Next, after absence seizure, the next CNS most important topic, antidepressant with sexual dysfunction. So SSRIs cause the maximum. SSRIs have the maximum sexual side effect. So if we have a patient who is having depression but he is unwilling to accept sexual side effects, what are the options that we have? So select mirtazapine, bupropion, paroxetine, vilazodone, venlafaxine. Out of these, the ones with minimal side effects. So let's see one by one. Paroxetine is an SSRI, and within SSRI it is the paroxetine which has maximum sexual side effect. So paroxetine in fact has maximum sexual side effect. So that is not going to be there. So any option that has 3 can be ruled out. Similarly, venlafaxine belongs to the SNRI category, and SNRI category also cause sexual side effect. So also SNRI have sexual side effect. So 5 is present in option number C. That is also not going to be the answer. Minimal sexual side effect is what we are trying to find out. So now what is left? Obviously we have the answer, that is option number B. So please remember mirtazapine, bupropion, vilazodone. These are some of the antidepressants which have minimal sexual dysfunction. So answer here is option number B. Remember the names of mirtazapine. Mirtazapine is also known as NASA. Bupropion is also known as NDRI, norepinephrine dopamine reuptake inhibitor. Vilazodone is a SERT inhibitor, serotonin reuptake inhibitor. But the question that is asked, it is a partial agonist on 5-HT1A. That is the question that is generally asked on vilazodone, partial agonist on 1A. That is also written very clearly in Goodman-Gilman as less incidences of sexual side effects. So answer is option number B. So second topic which is very important is sexual dysfunction. Now Avinash is saying, sir, if they ask which SSRI and which SNRI have least sexual side effect, what to tell? Fluoxamine can be same. Avinash, in general we believe SSRI and SNRI, both of these classes have sexual side effect. There is no comparative data to suggest that one of them has very low, but you can say generally you can write citalopram. Generally, if you have to choose, although I have not seen such questions, but if you have to choose, you can look for citalopram or fluoxamine. They may have less in comparison to other, but as I'm telling you, there is no definite comparative data available within each class. So in general, this question will not be asked. SSRI generally all of them cause sexual side effect, and so do SNRI. So that is the answer. Maximum obviously is paroxetine. So topic number 2, minimal or maximum sexual side effect. Topic number 3, lithium. So in lithium, they will ask either its use or side effects. Now side effects have been asked repeatedly over last few years. So I think now the examiner is looking for something more in lithium, and that brings us to the indications of lithium. So tell me the uses of lithium. All are indications of lithium. Okay, so side effects have been discussed a lot. Now I think it's time we move on with lithium, come to another point of lithium, that is the uses of lithium. So all are indications of lithium. Neutropenia. Yes, lithium can be used for treatment of neutropenia. Why? Because lithium has a side effect of causing leukocytosis. Leukocytosis can be caused by lithium, and that can help in neutropenia. Major depression is another use of lithium. Yes, very good. Lithium can be used, please remember, for major depressive disorder also, or for bipolar depression also. So lithium can be used as antidepressant, whether patient is having unipolar depression, that is MDD, or bipolar depression, lithium can be used. Lithium also finds rarely but possible use in migraine. So vasculogenic headache, vasodilatory headache, migraine is a possible use of lithium. So that is also true with lithium. Acute mania, yes, we do give lithium, although it is not drug of choice, but we start lithium in acute mania, not used in generalized anxiety disorder. Generalized anxiety disorder is the indication where lithium is not used. So these are the important indications of lithium out of the options 1, 2, 3 and 5. So option number A is the correct answer to question number 3 on lithium. So third important topic is lithium uses. So in lithium, please remember, besides the Side effects, which have been asked repeatedly. Uses are also important. One of the use that you should remember, lithium causes a side effect that we call as nephrogenic. Lithium causes a side effect that we call as nephrogenic diabetes insipidus. So it makes the kidney insensitive to ADH, that is nephrogenic diabetes insipidus. In theory, this side effect can also be used for treatment of SIADH. So lithium in theory can be applied for the treatment of rare cases of SIADH. So that is another possible use of lithium that you should remember. So acute mania, lithium is used. Migraine, lithium can be used. For depression, lithium can be used. Neutropenia and SIADH, these are some of the important uses of lithium. Okay, so everybody good? So third important topic is lithium. Okay, very important. And now focus on the uses. Side effects have been asked repeatedly. Next is problem of alcoholism and the drugs that are used to treat alcoholism, and one of the very important drug here is disulfiram. So question on disulfiram are also expected. Very important topic. Disulfiram. So if you people are liking the questions, the pattern, and you feel that these are the important points, do not hesitate yourself. Please like this session, give me some thumbs up, tell me about your feedback or your queries. Please continue to ask your queries. The more you ask, the more interesting, the more interactive the session becomes. So disulfiram, very important topic. Disulfiram, especially overall alcoholism and de-addiction is important, but disulfiram we are seeing from last 2-3 years is a very constantly asked topic in all the competitive exams, whether it is FMG or NEET or even INI-CET. So it's a very important drug. What is disulfiram going to do? First of all, we have to understand disulfiram. So alcohol, this diagram I am sure all of you are aware, but I will again draw this flow chart. Alcohol is converted into aldehyde by the enzyme alcohol dehydrogenase. And aldehyde is converted into acid by the enzyme aldehyde dehydrogenase. So first of all, disulfiram, which starts with the D. The spelling starts with the D. So please remember, disulfiram with a D will inhibit the enzyme with the D. So disulfiram is an inhibitor of aldehyde dehydrogenase. So that is the first thing you have to remember. And there is another drug that is known as fomepizole. Yes, fomepizole with an O is going to inhibit the enzyme which has O. So alcohol dehydrogenase with an O is inhibited by fomepizole. Disulfiram with a D inhibits aldehyde dehydrogenase. Number 1. What kind of inhibitor? It is an irreversible inhibitor. Irreversible inhibitor of aldehyde. So action will persist for 7 to 14 days after being stopped. So this is a true statement. Option number 1 is true. It is a true statement. Number 1. Anti-craving drug. Now anti-craving drug are drugs which reduce the craving for alcohol or the desire for drinking. Disulfiram is not an anti-craving drug. Please remember. What is disulfiram? Disulfiram, please remember, is the word aversion technique. It is an aversion technique. It is not an anti-craving drug. It does not reduce craving for alcohol. Does not reduce craving. It is used as an aversion. If you drink alcohol after taking disulfiram, instead of pleasure of alcohol, you will have unpleasurable symptoms. So it is an aversion technique, not anti-craving. So 2 is false. Respiratory depression and reduced consciousness if given with alcohol. This can occur if you take high dose of alcohol after taking disulfiram. So this is what happens. Patient is taking disulfiram. Now if this patient consumes alcohol, then depending on the amount of alcohol that he or she will consume, these are the symptoms that he will face. He will start having headache. He will start having flushing. He can also have some pruritus due to heat generation. He will also suffer gradually from hypotension. This can even lead to cardiovascular collapse, CVS collapse. So he will have unconsciousness also, plus there will be nausea, vomiting somewhere in between. So reduced consciousness can occur if you take too much alcohol with disulfiram. So that is true. Used in unmotivated patient, that is totally false. Disulfiram is used only in motivated patients. Those patients who are motivated to give up alcohol, only then we give disulfiram. Otherwise, we do not give disulfiram. So that is a false statement, and it is the best drug in patients who are physically dependent on alcohol. Absolutely false. If the patient is physically dependent on alcohol, never give disulfiram. So it is given only in motivated patients who are not dependent on alcohol. So 4 and 5 are false. So 1 and 3 are true. So that is option number D. That is the correct statement. Option number D. So Saurabh saying it is 1, 3 and 5. 5 is false. Best drug in physically dependent. This is false. So that is why option C is not the answer. It is the option number D. 1 and 3 are true. 5 is a false statement. So if patient is unmotivated or physically dependent on alcohol, never give this aversion technique. It is a drug that is given to reinforce the desire to give up alcohol. So if a patient is motivated to give up alcohol, but he has craving and he is unable to stop craving and keeps on drinking, that is why we give disulfiram as an aversion technique. So now physically dependent, you can use anti-craving drug, naltrexone or acamprosate. These are the drugs used in physically dependent patients. Sorry. Morphine should be avoided in which patients? Again, very important topic, morphine and its contraindications. Morphine and its contraindication, very important topic. It should be avoided in which patients? So another important topic is side effects or contraindications of morphine. So that is very important and very simple to remember. Very simple to remember. If you just draw a simple diagram, you will find you can remember the morphine contraindication. If you want, you can draw legs also. So you see, first of all, contraindications of morphine. If the patient has what we call as head injury, start with the top. If the patient has head injury, you will avoid morphine. Because it will increase intracranial pressure. That is number one. Head injury patient, you avoid morphine. Then if the patient has thyroid disease, if the patient has hypothyroidism, again you avoid morphine. I am not saying contraindicated, better to avoid. Why? Because there is exaggerated response to morphine in hypothyroid patient. So in hypothyroid patient, response of morphine can be exaggerated. Patient can go in respiratory depression. So try to avoid. Then you have lungs. What will happen? Morphine will cause histamine release. And that will cause bronchoconstriction. So definitely avoid in patients with history of asthma. So if patient has history of asthma, do not give morphine. Morphine will cause histamine release, cause bronchoconstriction. Patient has some problem with bile duct. It will cause spasm of biliary sphincter. So patient has biliary colic, or clinically more relevant, patient has undiagnosed abdominal pain. You don't know what is the cause of abdominal pain. It could be biliary colic. Do not give morphine. It causes further sphincter Contraction of biliary sphincter, pain worsens. So biliary colic patient avoid morphine. Avoid morphine. Okay, avoid morphine in biliary colic. Lastly, patient has renal disease. Patient has problem of kidney, renal disease. Try to avoid morphine. Again, I am not saying contraindicated. Why? Because there will be accumulation of morphine 3-glucuronide that will cause seizure. Morphine 3-glucuronide is a metabolite of morphine formed in liver, excreted in urine. So if there is renal disease, this M3G, morphine 3-glucuronide will not be excreted, it will cause seizure. So try to avoid morphine. These are the important situations where you will avoid morphine. So let's count. Head injury, avoid morphine. Hypothyroidism, try to avoid morphine. Asthma, or you can expect this to any respiratory disease. Patient has emphysema, patient has any respiratory disease, try to avoid morphine. Patient has undiagnosed biliary abdominal pain or biliary colic, avoid. Patient has renal dysfunction, try to avoid morphine. So out of these, option number 2, 3 and 4. These are the situations where we will avoid morphine. So option number C is the correct answer. Iris Samuel, excellent. Avinash, excellent. Very good. Very good. This is the diagram to help you remember where to avoid morphine. Okay, where to avoid morphine. Next question. Match the following. Very, very important pattern that we are seeing. Match the following in INICET. In INICET in November 2020, there were at least 5 to 6 questions on match the following. So it is very important for you to practice and practice with important topics. So treatment of neonatal seizures or childhood seizure is a very, very important topic. So let's see, we have some pediatric or childhood seizure mentioned, and let's see if we can match these to their correct drugs of choice. So first we have, start matching all of you. Let's see, status epilepticus. Status epilepticus, we treat it by giving intravenous lorazepam. That is the correct answer. So one goes with A. Status epilepticus, IV lorazepam is the best answer. Then we have infantile spasm. Infantile spasm. Only infantile spasm, I am looking for ACTH corticosteroid. Simple infantile spasm, I am treating with ACTH or prednisolone or corticosteroid. So 2 will go with D. 2 will go with D. Okay, infantile spasm, also known as West syndrome. EEG abnormalities, hips, arrhythmia. Okay, so that we teach by giving ACTH. Then we have infantile spasm with tuberous sclerosis. Now this is a special type of infantile spasm in which the child is also having skin condition, tuberous sclerosis. Now in this more severe variety of infantile spasm, we prefer vigabatrin. Vigabatrin is the drug of choice for infantile spasm with tuberous sclerosis. So 3 will go with B. 3 will go with B. Febrile seizure. Child has fever and due to fever he has seizure, febrile seizure. I am looking for again rectal diazepam conventionally has been the drug of choice. So 4 will go with C. 4 will go with C. Lennox-Gastaut syndrome. Lennox-Gastaut syndrome, LGS. Please remember, students frequently commit mistake. What is Lennox-Gastaut? Child will have multiple types of seizure. Multiple types of seizure. Along with that, you will be given mental retardation. This is going to be present in the MCQ. Low IQ will be given. Okay, so this will be given in the symptomatic presentation, and the drug of choice for LGS is believed to be valproate. So 5th goes with E, and that leaves us juvenile myoclonic epilepsy in pregnancy. So JME in pregnancy we treat with a drug considered safe in pregnancy. 6 goes with F. So that is what we are looking for. A, D, B, C, E, F. A, D, B, C, E, F. I find option number A to be the correct answer. And yes, Iris and Avinash, you are absolutely correct. So congratulations. This was a difficult question, but you have managed to solve it completely and accurately. So that is how you will match these questions. Please understand they will take time. Give at least 45 to 60 seconds in solving such questions. Do not hurry. Write as I have written in the side 1, 2, 3, 4, 5, 6, and then find the correct answer. So that is how. So Ashim, you have asked a very important question that out of levetiracetam or lamotrigine, which is considered better in pregnancy, answer is most safe. If you are looking for safest in pregnancy, that is levetiracetam to be preferred over lamotrigine. So if only safety is concerned, then levetiracetam is a better, or I would say safer drug in pregnancy with less teratogenicity than lamotrigine. Okay, so if you have to choose between two, this is what you will choose. So Usha KS, I think we have discussed. Answer is option number A. Option number A. Next. Read the question carefully. This is a clinical scenario. So I have given you till now two patterns of MCQ. One is multiple correct answers. Second is match the following. And third is the clinical scenario based question. So these are the three patterns of MCQ that we expect going forward in any exam. So we have a 50-year-old politician who suffers from severe anxiety. I think that is very well understood and expected given the nature of this profession. So he suffers from severe anxiety disorder with intermittent panic attack. Which of the following drug would be the preferred drug for long-term treatment? So patient has intermittent panic attack, severe anxiety. Which drug will be the best for long-term treatment? Yes. Ashim says D. So I am looking at panic attack word. Panic attack. For panic attack, if the patient is having panic attack, I am looking for the quickest anti-anxiety, and without any doubt that is benzodiazepine. So if I am asked the treatment of panic attack, without any doubt answer is benzodiazepine, and that would have been alprazolam. But that is not what is asked. What is asked is that this patient has intermittent panic attack, but right now we are trying to give him long-term treatment so that panic attack does not come or come with less frequency. So basically we are being asked treatment of panic disorder. The patient has panic disorder, a condition where patient has panic attack. So for panic disorder, we are looking for long-term treatment, not a very quick or short-term. So I will look for SSRI or buspirone. So these will be the two best drugs to be used for treatment of panic disorder for long-term treatment. Long-term, and that is what is asked, long-term treatment. So I am looking for SSRI or buspirone. SSRI is given, and that is the answer to this particular question. That is the answer. Please remember, benzodiazepines we generally avoid or we discourage long-term use of benzodiazepine. We give them for short-term only because of the problem of dependence and abuse liability. So long-term use of benzodiazepines is highly discouraged because of abuse liability. Ashim, now you again asked a very important question. SSRI in some cases, yes, that is true. SSRI in some cases can cause anxiety. But the percentage of individuals who develop anxiety from SSRI is far less than the people with anxiety benefited because of SSRI. Yes, so you can say that SSRI are associated with anxiety as a side effect, but that anxiety happens in a very, very less, or I would say minute percentage of depressed people. Okay, in general, SSRIs are good anti-anxiety drug. In fact, most antidepressants are. Okay, whether it is tricyclics, whether it is SNRI, they are also used as antidepressant, anti-anxiety. Now we have a 65-year-old patient of Parkinson's. PD is Parkinson's. He is receiving levodopa plus carbidopa since last 2 years. So Parkinson's we treat with levodopa and carbidopa. He has now developed hallucinations and confusion. So one of the side effects of levodopa that you should remember, one of the long-term side effect of levodopa therapy, by increasing dopamine in CNS. This can cause hallucination or psychosis. Patient can get psychotic symptoms, and that I think has happened. What would be the best drug to add for treatment of these psychotic symptoms? So patient has developed levodopa-induced psychosis. You are asked treatment of this particular condition. Treatment of this particular condition. So we have a patient who is taking levodopa. The patient, please remember, is a case of Parkinson. He is on levodopa therapy. Levodopa has increased his dopamine, and dopamine increase has caused psychosis. We are looking at levodopa-induced psychosis. For treatment of psychosis, we have two kind of drugs, antipsychotic. Okay, we have to give some antipsychotic. Antipsychotic, all of you are aware, are of two types. First generation antipsychotics, which are simply D2 receptor blocker, D2 blocker, and second generation antipsychotic, which are mainly serotonin blocker. So now the condition in front of us is levodopa-induced psychosis. So we have to understand which kind of antipsychotic we will use. So now it is very, very important to understand D2 blockers. If you give D2 blockers, they will abolish the action of levodopa. D2 blockers like chlorpromazine, haloperidol, they will block the action of levodopa. So patient will have worsening of Parkinson's. So we will not use first generation antipsychotic. What we will use is second generation antipsychotic. Second generation antipsychotic will be used for treatment of levodopa-induced psychotic. So there are three drugs which are used. One very specific atypical or second generation that has been developed is known as pimavanserin. Pimavanserin is a specific second generation antipsychotic for levodopa-induced psychosis. Besides that, you can also use quetiapine, again second generation. In very severe cases, you can also go for clozapine. So these are the three drugs which are commonly used for levodopa-induced psychosis, with pimavanserin being a very specific drug for levodopa-induced psychosis. So the logic behind question is, it is the combination of Parkinson and psychosis treatment. So you have to understand levodopa is the drug of choice for Parkinson's disease, but levodopa can cause side effect of psychosis. If psychosis occurs due to levodopa, we will never use first generation, we will always use second generation antipsychotic. And which second generation? Remember the name pimavanserin, quetiapine or clozapine. These are the three which are commonly used. Okay. So that is how, yes Anjana, that is correct. Pimavanserin, Manas, you are absolutely good. And Ashim also, you are correct. So I hope you have understood. This is a drug interaction question. Okay, drug interaction. In levodopa and psychosis, what is the drug interaction if you give antipsychotic? So that is what you remember. Lithium is not used as antipsychotic, so that will not be the answer. Now we have a question which says, before starting natalizumab therapy for MS, MS is multiple sclerosis, a patient should be screened for. So before starting natalizumab for multiple sclerosis, a patient should be screened for simple direct question, very important drug, natalizumab, known as anti-integrin therapy. Anti-integrin therapy, it blocks the alpha 4 beta 3 integrin, prevents the attachment of leukocytes to endothelium, prevents leukocyte efflux from the blood vessel, anti-integrin therapy. What is the screening done before starting natalizumab? Yes. So Vinash, Anjana, very good. Manas, very, very good. We will screen the individual for antibody against John Cunningham virus or JC virus. So this drug, natalizumab, which is anti-integrin, has a side effect of causing progressive, P for progressive multifocal leukoencephalopathy, PML, and in short as it is known as PML, which is thought to be caused by the JC virus. So if you want to increase or if you want to start natalizumab, first screen the patient for antibody against JC virus. If the patient has JC virus antibody, that means he is exposed to JC virus, do not give natalizumab. Because of which risk? Progressive multifocal leukoencephalopathy, PML, very good approval. Usha, not for ECG, I'll come to that also. So anti-integrin therapy, natalizumab, what is the risk? Progressive multifocal leukoencephalopathy caused by which virus? JC virus. So screen for what? Antibody against JC virus. Okay, that is about natalizumab. Then you have some other options. PPT testing for latent TB. You will screen a patient for latent TB before starting which drugs? Tell me, this is also an important question which is asked. PPD, purified protein derivative testing for latent TB. This is done before starting which kind of drug? Tell me, this is done before starting which kind of drugs? PPD testing. Which type of drug you screen a patient for before starting this drug? You screen the patient for PPD. Anjana, you say when we give biologics, but that is correct, but the specific answer is before starting anti-TNF alpha drugs. So before starting anti-TNF alpha, you will screen the patient for TB by giving purified protein derivative. So please remember two things. Before starting natalizumab in multiple sclerosis, screen for JC virus antibody, and before starting anti-TNF alpha, mainly in rheumatoid arthritis, screen for TB. So these are two important questions. Prabhakar, you are saying interleukin antagonist. Now interleukin, you see interleukin antagonist would be a very vague answer because there is interleukin 1 antagonist, 2 antagonist, 6 antagonist, 12 antagonist, 23 antagonist. So tocilizumab increases, so we can, but it is not mandated. The best answer is anti-TNF alpha. Whenever you want to start, screen for latent TB. Okay. Now, after important topics of CNS, so multiple sclerosis, alcohol de-addiction, lithium, antidepressants with sexual side effect, absence seizure, treatment of childhood seizure. These are some morphine. These are some important topics in CNS. Now we come to hormones or endocrine. So OCP act by all of the following mechanism except OCP, whether in gynecology or pharmacology, are very important topic. So OCP act by all of the following mechanism except. Tell me. So OCP mechanism is very simple to remember. All you have to do is draw the female reproductive system. Very simple diagram you draw, and you can remember the mechanism of all important OCPs. So this is what you can consider as ovary. O for ovary. Ovary releases ovum. Okay, so this is ovum. So first is we will inhibit the ovulation. Ovulation you inhibit, ovulation inhibitor. Now this is the most common mechanism of combined OCP. Okay, please remember, most common mechanism of combined OCP inhibiting ovulation. Both estrogen and progesterone inhibit ovulation. Then sperms are going to enter, so make the cervical mucus thick. So that is important method, preventing the entry of sperm, making the cervical mucus thick. And this is the most important mechanism of the mini pill or progesterone only pill. Progesterone only pill are the ones which make the cervical mucus thick. So that is the main mechanism of progesterone only pill, making the cervical mucus thick. Finally, the ovum and the sperm, once they will fuse, they will create a zygote, and now the zygote has to implant here, implant on somewhere on the uterine cavity. So we will inhibit this process, and that is implantation. You will inhibit what? Implantation. Implantation will be inhibited, and this is the most important mechanism for what we call as post-coital or emergency contraception. Inhibiting what? Implantation. So 3 questions are asked and all 3 can be answered. Most common mechanism of oral contraceptive pills inhibiting ovulation, most common mechanism. Most common important mechanism of post-coital pill preventing implantation. Most important effect of progesterone only pill making the cervical mucus thick. So A, B, C, all are mechanisms of OCP except answer is D. Increasing gonadotropin release is not going to benefit in prevention of pregnancy. That may cause in fact pregnancy. So I hope it is clear. 3 mechanism, 3 question. Somebody asked how do OCP act? Inhibit ovulation. How do progesterone only pill act? Mainly cervical mucus thickening. How do post-coital pills act? Preventing implantation. All 3 you remember all mechanisms of contraception. Coming to very important, rather very important topic, post-coital contraception. So please remember the topics. As I said, topics are important. Emergency or post-coital contraception, which is not used. Not used. This should be on your tips. On your tips. So first is till 72 hours. Till 72 hours, what all you can give. What all you can give. So I hope everybody is till this stage. Anybody who has attended my class should be clear. We can give what? Combined OCP, also known as USP method. We can give levonorgestrel alone. And in some countries like Japan, only few countries allow this. High dose of estrogen can also be given. In India and most Western countries, this high dose estrogen is not allowed. But in some countries, Japan, South Korea, it is given. So till 72 hours of unprotected intercourse, you can give combined OCP, levonorgestrel alone, or high dose of estrogen. Then till 120 hours, what you can do? You can give RU486. So what is RU486? It is another name of mifepristone. So this is a source of confusion. KDT says only mifepristone can be given till 72 hours, but if you read the Bible of pharmacology, that is Goodman and Gilman, if you go to the WHO website, you will find now it is used till 120 hours. So that should not be a source of confusion. First, next we can give a new progesterone modulator, ulipristal, or we can do a non-drug treatment, that is intrauterine copper device. So RU486 can be given. Danazol is not used for emergency contraception. Yes, that is correct. Apurva, very good. Also good. Anjana, Vinash, very good. All of you. Danazol is mainly used in hereditary angioneurotic edema. It is used for fibrocystic disease of breast. Fibrocystic disease of breast. It is also used sometime for menorrhagia. It is not used for the post-coital contraception. So next important topic, keep marking the topic, that is very important, emergency contraception. All of the following drugs increase bone formation. Very commonly asked question, increase bone formation. But the catch here is except. So there are many drugs nowadays which increase bone formation available in market, and you have to tell me all of the following increase bone formation except. Yes, quickly. I hope you are enjoying the session. I hope the questions are exciting and interesting. They are neither too simple nor too difficult. and you feel that they are coming from the important topics, the topics that you cannot afford to miss. So the aim here is not to give very difficult or very easy questions. The aim is to give you those questions which are likely to come in the exam. Okay. So if you like that, please do not prevent yourself from giving a bit of thumbs up. Okay. That is good. Increase in bone formation. Teriparatide, a recombinant PTH, increases bone formation. Remember the drug abaloparatide. It is a parathyroid hormone related peptide. Parathyroid hormone related peptide that also increases bone formation. Romosozumab. It's a monoclonal antibody, as the name suggests, MAB, against a protein present in bone known as sclerostin. So when sclerostin is inhibited or blocked, bone formation increases. So all these three drugs increase bone formation. All of them increase bone formation. So obviously the answer is denosumab. Denosumab, please remember, an antibody that blocks rank ligand. Antibody against rank ligand. So it will block rank ligand, and what it will do, it will decrease resorption of bone by killing osteoclast. Bone resorption will decrease. Denosumab. So three drugs that increase bone formation. There is also one drug that we call as strontium ranelate. The drug is very rarely used, but it is believed to increase formation of bone also, and at the same time decrease bone resorption also. But as I said, the drug exists more or less in theory, not a very practical or popular drug, so never any question has been asked. Okay, all these drugs which increase bone formation, all of them are subcutaneous. Teriparatide, abaloparatide, romosozumab, all are subcutaneous. Next, very important question, both in pediatric, pharmacology, even in medicine, even in physiology. So such type of questions which require knowledge from multiple subjects are, I think, the flavor of the season. So a child has been diagnosed with vitamin D dependent rickets. The most appropriate vitamin D preparation for him. So first of all, you should know what is vitamin D dependent rickets. So what we have is known as cholecalciferol. I'll simply call it vitamin D3. Now this is found in skin. This is found in skin by action of ultraviolet rays on cholesterol. So this is found in our body, cholecalciferol. What happens? This will go to liver first of all and will be converted into 25 hydroxy D3. So 25th position, liver will add a hydroxy group. Now this becomes what we call as calciferol. Further, this substance moves to kidney, and this is very important for you to remember. In kidney, it will be undergoing another hydroxylation. Now it will become 125 dihydroxy D3, and that is known as calcitriol. So there is what? A 25 hydroxy D3 hydroxylase, or there is, you can say, a simple language, hydroxylase enzyme in kidney. Please understand two things only, and just two things. What is happening in kidney? What is happening in kidney is hydroxylation. Okay, one OH group is coming. Where? At which position? One position. 25th position liver is acting, and one position kidney is acting, and this is the active form of vitamin D. What is vitamin D dependent rickets? Vitamin D dependent rickets occurs when the child has absence of this enzyme. This enzyme is absent, the final activation of vitamin D cannot occur. This hydroxylase enzyme in kidney is absent, so 25 hydroxylase D3 cannot go into 125 dihydroxy D3. So calcitriol cannot be formed by this child. You will have to give calcitriol from outside. That is the only situation where calcitriol is used. Calcitriol is used. In all other vitamin D deficiency, we give cholecalciferol. It goes to liver. Liver adds 25 hydroxy. Then it goes to kidney. Kidney adds one more hydroxy. Substance becomes active and performs. So in normal vitamin D deficiency, we give cholecalciferol. But if there is child with vitamin D dependent rickets, that means kidney is not working, hydroxylase enzyme is absent, you will have to give calcitriol, the most active form of vitamin D. So very important, sequence of events, vitamin D goes from skin to liver and liver to kidney. From cholecalciferol to calcifediol to calcitriol, all questions have been asked. All questions have been asked. So whether you read this in pediatrics or in pharmacology or in physiology. Remember, light is falling, skin is forming D3 cholecalciferol. That will go to your liver, calcifediol, one OH group is added. Then it will go to kidney, another OH group is added, then it becomes active or calcitriol. So if kidney failure is there or vitamin D dependent rickets, you will have to give calcitriol. Next question. Use of tamoxifen. Very important. I would say one of the most important topic in pharmacology right now is tamoxifen, SERM. SERM, selective estrogen receptor modulator. For carcinoma of breast, when you use it, can lead to following side effects. So what are the side effects? Thank you, Avinash. Thank you, Anjana. Very encouraging comments. I cannot thank you enough for your comments. It is really appreciation of students like you which keeps us all the educators going at Unacademy. So this is just a snapshot. I'll show you on Saturday 3 sessions lined up where we will discuss in more detail all the important topics of pharmacology in the latest pattern. So we'll come to that also. Tamoxifen. Now please remember tamoxifen. It is a SERM. What it will do in different organs in breast. It is anti-estrogenic. It will decrease proliferation of breast. So it is used for breast cancer. In bone it is pro-estrogenic, like estrogen, so it will increase mineralization. So it can benefit osteoporosis. So it will not cause osteoporosis, number 1. Fifth is not a side effect, so C and D options are gone. So in bone, tamoxifen is like estrogen, causes mineralization. Then in uterus, again it is like estrogen, it causes proliferation, increase in proliferation will occur, so it can increase the risk of uterine cancer. So this is a potential side effect. In liver, it is again like estrogen, it increases, please remember, clotting factor synthesis, clotting factor go up, so thromboembolism can occur. So this is a potential side effect. And besides that, in eye, please remember, it causes both cataract also, and it can even cause retinopathy. Retinopathy can also occur in eye, ocular side effect, and also it increases the post-menopausal symptoms like hot flushes. So these are the effects of tamoxifen in one slide for you. So it increases cataract, it increases thromboembolism, it increases endometrial cancer, it increases hot flushes, but it will not cause breast tissue proliferation. It will decrease breast tissue proliferation. So it will not increase cancer in opposite breast, it will decrease. So 1, 2 and 3 are side effect. Option number A is the answer. Option number A. Option number A. Yes, Manas correct, Iris correct. Hepatic adenoma may occur, but the important action is increase in clotting factor synthesis in liver that we are interested in. So these are the side effects 1, 2 and 3. Also add hot flushes to it and you have the side effect profile of tamoxifen. Next we have not correctly matched to its side effect. Not correctly matched. And which kind of drugs are given? Anti-diabetic drugs. So how can we complete endocrinology without coming to anti-diabetic drug? That would be criminal. So anti-diabetic drug, not correctly matched. Exenatide, GLP agonist. GLP-1 agonist causes pancreatitis? Yes, that is correct. Dapagliflozin, SGLT2 inhibitor. SGLT2 inhibitor, vaginal candidiasis, yes. They increase glucose loss in urine that can cause vaginal mycotic infection. Pioglitazone. Pioglitazone. Remember, rosiglitazone was banned because it was causing cardiac events, MI, CHF. They can cause water retention. Rosi and pioglitazone, yes, that is true. Sitagliptin, DPP4 inhibitor. DPP4 inhibitor, sitagliptin. Nasopharyngitis, yes. Yes, that has been seen. Acarbose, alpha glucosidase inhibitor. Hypoglycemia, no. No. Acarbose rarely causes hypoglycemia. The main problem of acarbose is GI disturbances like flatulence, dyspepsia. So these alpha glucosidase inhibitor, they are not given if patient has history of inflammatory bowel disease. If patient already has abdominal complaint, do not give. And another side effect of acarbose is hepatotoxicity. Hepatotoxicity. But hypoglycemia is not a common problem with acarbose. So which is not correctly matched, E is not correctly matched. Hypoglycemia, if you want to know, commonly hypoglycemia will be seen with drugs that increase insulin release. Increase insulin release, and the two most important oral drugs, sulfonylurea and meglitinide. To some extent, very rarely, even GLP-1 agonist may cause, but very rare. Normally, these are the two drugs. Obviously, insulin will cause, but sulfonylurea, meglitinide cause hypoglycemia in diabetes. So, answer is A. Ashim, also remember meglitinide, that is repaglinide, netiglinide, same mechanism as sulfonylurea, also causing hypoglycemia. Now we have a question on thyroid, hyperthyroidism, anti-thyroid drug. You see one question and you will remember everything about hyperthyroidism treatment. One question, match the following, and everything about hyperthyroidism will flash back in front of you and it will be crystal clear. So match the drug in column A. And you all will appreciate these are not the questions that you find in any of the book, any of the online classes. These are genuine new questions which I have personally made, which summarize the important topic and all the important lines from that topic. So if you just revise these questions, you will find that the entire topic is reversed. So match the drug in column A with its role in hyperthyroidism in column B. Iodine 131. Radioactive iodine. Iodine 131 is used in patients who are elderly, not fit for surgery, toxic thyroid nodule in 80-year-old patient. Basically, patient who is not fit for surgery. So we have an elderly patient or a cardiac ischemic disease patient and we have hyperthyroidism, we give radioactive iodine. Lugol's iodine. Iodides, potassium iodide in iodine is Lugol's iodine, that is used for pre-operative preparation. Pre-operative preparation. So one is going with C, two is going with A. Lugol's iodine, that is potassium iodide in iodine, it decreases the blood supply to gland, makes it smaller. We can give it pre-operatively. Two goes with A. Propyl thiouracil, PTU. We all know PTU is used in two situations. One of them is pregnancy. So it is considered safer in pregnancy, at least in first trimester. It is the drug of choice. So 3 goes with B. And that leaves carbimazole or methimazole, which is the drug overall hyperthyroidism. Without A, B or C is carbimazole. So 4 goes with D, CABD. So I am looking for CABD and I find option number C. Option number C. Option number C. So any kind of hyperthyroidism, these are the 4 types asked. Drug of choice for hyperthyroidism, nothing else is given, carbimazole. Drug of choice in pregnancy, PT. Pre-operatively, which drug will you give? Lugol's iodine or potassium iodide. And if patient is not fit for surgery, we give radioactive iodine. These are the only 4 situations One more that is asked is Thyroid Storm. What is the drug of choice for Thyroid Storm? Yes, please, anyone tell me what is the drug of choice for Thyroid Storm? What do you took? Thyroid Storm. What will you take in Thyroid Storm? Is anyone? Drug of choice in Thyroid Storm. That is the only question remaining about the treatment of hyperthyroidism that is asked. Drug of choice for Thyroid Storm, please remember, drug of choice is PTU, propyl thiouracil. PTU is the drug of choice. What else do you give? You also give beta blocker for symptomatic control, and you also give the iodides or Lugol's iodine. But drug of choice is PTU. Do not commit that mistake that beta blocker are drug of choice. Beta blockers are given, but they are not drug of choice. Drug of choice remains PTU because it can inhibit peripheral conversion. So that property of PTU, it is the first drug to be given, best drug to be given, most important drug to be given, drug of choice PTU. PT. Next question. So after endocrinology and CNS, I told you we will also take up HEMAT. So I have some very important questions from HEMAT. Obviously we are running short on time, so we'll try to hurry up a bit. Dose of warfarin. So warfarin drug interactions are very, very important topic, should be reduced in all except. This is a very tricky question. You want to reduce dose of warfarin. Dose will be reduced when you have increased effect of warfarin. Any condition that will increase effect of warfarin, you would like to decrease the dose. So let's see one by one. Alcoholic with liver disease. If there is liver disease, what will happen? In liver disease, liver is not working, so there is decreased clotting factor synthesis, because clotting factors are synthesized in liver. So if clotting factor synthesis decrease, effect of warfarin will increase and you would like to decrease the dose, obviously. Clear? Female with hyperthyroidism, it could be even a male with hyperthyroidism. What will happen in hyperthyroidism? Metabolism will go up in hyperthyroidism, so it will also increase the metabolism or breakdown. It will increase the breakdown of clotting factors. Protein breakdown will increase. So again, level of clotting factor will decrease. Effect of warfarin will increase. Adult male on broad spectrum antibiotic. Broad spectrum antibiotic will kill the GI flora. When GI flora will be killed, again it will decrease clotting factor synthesis, because vitamin K is formed by GI flora. If GI flora is killed, vitamin K production goes down. Vitamin K goes down, clotting factor synthesis goes down, effect of warfarin increases. So in A, B and D, you would like to decrease the dose. So correct answer is option number C. Nephrotic syndrome characterized by albuminuria. And please remember, warfarin is a highly plasma protein bound drug. So along with albuminuria, the warfarin attached to albumin will also increase. So it will increase the excretion, urinary excretion of warfarin. So effect actually will decrease and you will have to actually increase the dose in proteinuria in nephrotic syndrome. Avinash, you are saying RAI any relation with age? I am not very clear what do you mean by RAI. Could you expand that a bit? So answer here is C. So please remember, liver disease, you decrease the dose. Thyroid excessive action, you decrease the dose. Broad spectrum antibiotic, you decrease the dose. But if child has nephrotic syndrome, you have to increase the dose. Next question, very important question. This is one question, one topic which I always like. We have a 22-year-old female who consumed 30 tablets of ferrous sulfate. Now please remember, iron poisoning is either in child who accidentally ingests the ferrous tablet or suicide. आयरन की पॉइजनिंग दो ही कॉमन है, या तो बच्चे ने ज्यादा एक्सीडेंटल टैबलेट पूरी बॉक्स उठा के उसने खा लिया, या सुसाइड। तो यहाँ पे सुसाइड अटेम्प्ट है। She was presented to M emergency with severe vomiting, etc., etc. All would be useful except. So we are asked about treatment of iron poisoning. Iron poisoning में क्या नहीं करना है? Good evening, Ram Akhtar, Dr. Ram Akhtar. Good to have you. Now you see what is to be done. We will deal later in iron poisoning. What is contraindicated that you have to remember, and the substance is ball. Now ball is very interesting substance. Ball stands for, you see, ball. Bismuth, A for arsenic, L for lithium. Bismuth, arsenic, lithium. In these three poisoning, you can use ball. Okay, you can use ball. In bismuth, arsenic, and lithium, you can use ball. Okay, but then AB is followed by CD, that means cadmium, and CD is followed by EF, that means iron. So in these two poisoning, cadmium and iron, ball is contraindicated. So everything that you need to know about ball, British anti-leucocide is written in its name. Bismuth, arsenic, lithium, you can use it. In after AB you come to CD, cadmium, it is contraindicated, and after CD you come to EF, ferrous, Fe is ferrous. In iron and cadmium it is contraindicated. Simple. So ball is not going to be used in iron poisoning, because the chelate of ball with iron is also toxic. So it will chelate iron, no doubt, but that chelate is also toxic. So in cadmium and ferrous poisoning, ball is contraindicated. That's the answer. The drug of choice is Desferrioxamine. Mostly we give it IM. If shock is present, then we give it IV. So that is the drug of choice for acute iron poisoning, Desferrioxamine. Desferrioxamine, iron chelator. Yes, Dr. Galva, absolutely correct. You are right on the spot there. Ball is contraindicated in CD and iron poisoning, and it is used in bismuth, arsenic, and lithium. So easily it can be used. Then in the hematology, after warfarin, after iron, nicotinic acid should be avoided in all patients. Very important drug, nicotinic acid, from the hypolipidemic drug. Nicotinic acid. Nicotinic acid, all of you should know, inhibits the hormone sensitive lipase. It inhibits hormone sensitive lipase in adipose. So hormone sensitive lipase in adipose is blocked. So triglycerides, which break into free fatty acid, this is not going to happen because hormone sensitive lipase is stopped. So free fatty acid will not be available to liver. Free fatty acid will not be available. Liver cannot form triglyceride. Liver cannot form triglyceride. So nicotinic acid decreases triglyceride level mainly. It also increases HDL level. These are the two actions of nicotinic acid. However, the question is asking it should be avoided. Where it should be avoided? The mnemonic you have to remember is simple mnemonic. You will avoid in PG diploma. Where will you avoid? You will avoid nicotinic acid in where? PG diploma. Where? What does P stand for? P stands for peptic ulcer disease. Peptic ulcer disease. Why? Nicotinic acid causes a lot of dyspepsia. Dyspepsia, bloating, abdominal pain, lot of their complaint is there. You will not give in patient with history of peptic ulcer. It is avoided. G stands for patients with gout. You will not give nicotinic acid in patients with gout. Why? Because it simply causes hyperuricemia. Uric acid level goes up with nicotinic acid. So PG. And D, you will not give in patients of diabetes. Why? Because it can cause hyperglycemia. Hyperglycemia, it is going to be avoided. So A, B, C, it is avoided. D, it is given. It is the best drug so far to increase HDL level, as I have told you. So it is given in patients with low HDL. So that is the situation where it is not avoided. Where it is avoided, PG diploma, and also it is hepatotoxic. So patient with history of hepatitis can also avoid nicotinic acid. So P for peptic ulcer disease, G for gout, and D for diabetes. PG diploma, you will avoid nicotinic acid. What it does, decreases triglyceride, mainly increases HDL. So that is about nicotinic acid. Very, very important topic, nicotinic acid in hypolipidemic. So that brings us to the end of this session, where I tried to discuss some of the most important topics, MCQs, latest pattern related to the upcoming NEET. Although it is unfortunate that the NEET, which was due to happen on 18th, has been postponed. We do not know when it will happen. So it is slightly disappointing, but we cannot allow this delay or postponement to hamper our preparation. We have to be even more determined, devoted, and ready for challenge. So now is the time not to get disappointed, disheartened, but to prepare with even more enthusiasm. So today we have completed the first part. I will be back tomorrow with the part 2 also of the NEET, most important. We will cover CVS, antimicrobial, cancer, some other important topics. Same time, 9 p.m. on YouTube channel. So these sessions are quite brief. We have to, on the YouTube we discuss with limitation of time. But that is why on 17th of March, that is Saturday, on the Unacademy app, there will be 3 sessions. Starting 9 a.m. there will be part 1, part 2 and part 3. 3 sessions I take on the Unacademy app on the coming Saturday. All the latest pattern and all the important topics. So this is what we have seen, just a snapshot, just a highlight. The main topics, all of them from all the units of pharmacology will be covered on 17th of March. So do not miss out on these sessions. Timings I'll post soon. So keep watching this channel for the timings. And if you are a new visitor to this particular channel, please download the Unacademy app and use the code Dr. Arpit Agarwal to unlock these free sessions. So this is going to be a free session. You will need the code Dr. Arpit Agarwal if you are the first time downloader of the Unacademy app. That brings us to the end. If there is any medical student who has not yet downloaded the Unacademy app, please do it right away. In these COVID times, where going out is extremely unsafe, sitting in offline coaching classes is not advisable. It is the best learning app. Plus, it brings you all the top educators at the single platform. So if you have not downloaded, please download it right now and use the code. Remember the code. What is the code? Remember the code Dr. Arpit. Remember this code Dr. Arpit Agarwal without any space in between. Use this code and unlock the free classes. And see for yourself how good Unacademy is. Okay. So that's all from my side. I hope you like this particular video, this session. If you like, please do not forget to hit the like button. Also equally important is to share it with your friends. Share it with your friends, with your seniors, with your juniors. Share it among your college WhatsApp and Telegram groups. And hit the bell icon so that you get the timely notification of my upcoming classes. So thank you all, Iris, Dr. Galva, Avinash, Anjana for joining. I'll be back tomorrow, same time 9 p.m. with another episode of the most important topics in pharmacology. Thank you all. Have a very wonderful night.